Conn syndrome is basically due to the hyperaldosteronism. Hyperaldosteronism. So, just to recap, so we have GFR, glomerulosa, fasciculata, and reticularis, and that's the components of the cortex, adrenal cortex. And Conn syndrome when the patient have the hyperaldosteronism. So let's recap what's actually aldosterone does. So basically, we have the efferent, and we have the glomerulus inside the capsule lumen, and these capsule lumens will turn to become the proximal convoluted tubules and loop of Henle, and this is convoluted and in the collecting ducts. Really, what aldosterone does is actually in the ROS, which is the renin, angiotensin, and aldosterone system. Basically, it's to increase the BP. So what we have here, when there is a low in BP or low sodium, the macula densa here will detect these conditions. It's from macula densa, basically a cell's lining from the discombinatic tubules, and give a signal to the juxtaglomerulus apparatus. The juxtaglomerulus apparatus, and the juxtaglomerulus will produce renin. Renin basically will stimulate the angiotensinogen from the liver, to be renin will cause the angiotensinogen to convert into the angiotensin 1. So in the lung, this is also the question that they frequently ask. In the lung, there will be when these conditions happen, so basically the carotid sinus, the baroreceptor and the carotid sinus can also detect the conditions of the low BPs. So they will start to stimulate the angiotensin converting enzyme. So angiotensin 1 will be converted by ACE into angiotensin 2, and angiotensin 2 will stimulate the aldosterone from the glomerulosa to produce aldosterone. So what aldosterone does is actually back to the distal convoluted tubules and also the collecting duct. What it does is actually they pump in the sodium into the blood vessels. So this one will become urine. So the sodium inside the collecting ducts will be transported into the blood vessels. So the sodium together with the water will be resorbed into the collecting ducts. So the sodium will become high, so hyponatremia, increase of the water, and this causes increase in the volume, so the BP will be increased. And in order to pump in the sodium, it needs to exchange with the potassium. So the potassium will become low in hyperaldosteronism. So how do we investigate this condition? So we can simply take the renin an aldosterone level and see in the primary aldosteronism, in which when there's a secretions of the aldosterone primarily from the glomerulosa layer, then the aldosterone will be high in regards of the renin, so renin might be low. But in secondary aldosteronism, what happened is that, for example, there is a coarctations of aorta, or there's a compressions or renal artery stenosis, or coarctations. There will be low BP in the renal artery, causing the macula densa to stimulate the RA system and cause increase in the aldosterone. So in the blood test, we can see the renin is high due to this, and also thus causing the high in the aldosterone. So that is how you can investigate on that. So while in Cushing, there is a two difference between Cushing syndrome and Cushing disease, whereby when we talk about Cushing disease, basically it referred to the pituitary adenoma. So what happened is that we have the brain here with the anterior pituitary, pons. So the hypothalamus will secrete the CRH, the corticotrophin releasing hormone, and causing stimulations to the anterior pituitary to produce the ACTH, adrenocorticothyroid hormone. So basically it will stimulate the cortisol at the layer of the fasciculata. So what cortisol does, first of all, it causes the increase in the gluconeogenesis. So if you really see the definitions here, gluco is glucose, neo is the new, and genesis is the formations. So formations of the glucose from the new source. So what really does this mean is that when in fasting, when you don't have a carb in the carbohydrate to break it down into glucose, the body will start the gluconeogenesis, whereby the body will produce glucose from the fats, from the amino acid, so basically what happened in gluconeogenesis, you can see there's a lipolysis. There will be increase in the protein breakdown or catabolism, amino acids, so that all of this can produce what we call a pyruvate, and pyruvate can get into the cycle of gluconeogenesis to become glucose again. So protein catabolism, and this condition is also very important to have insulin resistance, because at this point when in the stress condition and cortisol will be produced, or in the fight and flight condition where the body need more energy, and also they become insulin resistant, so that the glucose will remain in the body to be used by the brain and also the muscles itself, and there will be increase in the fat deposition. So the question that I want to ask, why a patient with Cushing syndrome will have increase in the central obesity? Just like after we did some physical exertions, later after the physical exertions, really we're gonna feel hungry. So in the Cushing syndrome, when there is no stressor or physical activities, still the body detects higher cortisol, so they become hungry and cause a central obesity. And really hypercortisolism will cause reduce in the immune system, or we call immunosuppression. This is very important, especially just imagine when you want to fight on something, you have less pain, but it will increase the infectivity. So this mechanism is very important during this stress condition. And lastly, because you want to make sure you have enough glucose and also for the muscle contraction for the body to work, the body needs calcium. So cortisol will increase the osteoclast activity. By means, they will break down the calcium from the bone, causing the bone to lose the calcium density and become osteopenic penia or osteoporosis. So how do we investigate these conditions? So the investigations can be done by two ways. First, the low dexamethasone suppression test. Second one is the high DEXA suppression test, which means the low dexamethasone suppression test means we give, since we know cortisol is high in the morning when the body start to works, even your office start at 8 a.m. So the highest cortisol level is in the morning. So we give dexamethasone low dose 1 milligram of DEXA 10 p.m. at night, and then we look at the level of the ACTH and also cortisol in the next morning at 9 or 8 or 9 a.m. So what happened? In a normal conditions, when you give a dexamethasone, basically it will give when you give a dexamethasone, so you increase the cortisol here, it will give a negative feedback to the ACTH and also the CRH. So logically, in a normal condition, you're gonna find the ACTH to be low and cortisol will be low because you've given it and it has been enough in the circulation. But in Cushing syndrome, when with a small dose of the suppression in the conditions where cortisol already high, it won't able to give a negative feedback to ACTH, so ACTH will be high in the Cushing syndrome. So if you found this, you have to proceed with the high dexamethasone suppression test using 8 milligram. So using 8 milligram, you can differentiate whether it's a Cushing syndrome or it's actually Cushing disease, which primarily come from the pituitary adenoma. So if in pituitary adenoma, regardless of the cortisol that you've tried to suppress, we give a high dose of cortisol here, and 8 milligram is actually enough to inhibit the ACTH. So ACTH will be low in next morning, and so the cortisol. That is if it's a pituitary adenoma. But what if you have some adrenal origin of Cushing? Adrenal Cushing. So regardless of this suppression, anyhow, with the high level of cortisol here, because it's primarily produced by the adrenal gland, which is the fascicular layer, it is still unable to actually inhibit the ACTH. So in adrenal, with the high level of the cortisol given, the ACTH will be low and the cortisol will be high. But if you have a lung tumor which produce lung ACTH tumor, regardless of the high suppressions that it gave, you will have to find the cortisol is high and the ACTH is high, because ACTH was ectopically released by the lung